Welcome to AZIN's Journal Club, episode 54. I am Dr. Z, and KC is with me. Today we are covering a trial that is reshaping how we think about intermediate-risk pulmonary embolism management. The PEERLESS trial, published in Circulation in February 2025. The primary results were actually presented at a major conference in October 2024. KC introduced the clinical context.
Pulmonary embolism is a spectrum. High-risk or massive pulmonary embolism means the patient is in shock or cardiac arrest, and those patients need immediate systemic thrombolysis or surgical embolectomy. Low-risk pulmonary embolism means anticoagulation alone is sufficient, and many patients can be discharged. The challenging middle ground is intermediate risk, sometimes called submassive, pulmonary embolism. The patient has hemodynamic stability, but evidence of right ventricular strain on imaging or echocardiography. These patients can deteriorate and have significant mortality if not managed carefully.
The traditional options for intermediate-risk pulmonary embolism have been anticoagulation alone, systemic thrombolysis, which carries significant bleeding risk, including intracranial hemorrhage, or catheter-directed thrombolysis, where you deliver a much lower dose of thrombolytic directly into the pulmonary artery thrombus via catheter. More recently, large-bore mechanical thrombectomy emerged as an option, where you literally suck out the clot using a device like the Interme FlowTriever system without using any thrombolytic drug at all. The PEERLESS trial compared large-bore mechanical thrombectomy head-to-head against catheter-directed thrombolysis. KC, the design.
PEERLESS was a multi-center open-label randomized controlled trial enrolling 550 patients at sites across the United States and internationally. Patients had intermediate high-risk pulmonary embolism with right ventricular dysfunction on imaging, PACI class 3 to 4 or simplified PACI of 1 or higher, systolic blood pressure above 90 millimeters of mercury, and main or lobar pulmonary artery thrombus. They were randomized 1:1, 274 to large-bore mechanical thrombectomy with a FlowTriever system, 276 to catheter-directed thrombolysis. Follow-up was 30 days.
What was the primary outcome?
A composite of death, intracranial hemorrhage, clinical deterioration, defined as escalation to massive pulmonary embolism, requiring cardiopulmonary resuscitation, mechanical ventilation, or vasopressors, or major bleeding within 48 hours. Large-bore mechanical thrombectomy was superior, 4.7% versus 17.9% in the catheter-directed thrombolysis group. That is an absolute risk reduction of about 13 percentage points and a highly statistically significant result.
13 percentage points absolute risk reduction is substantial. What was driving that difference?
Primarily clinical deterioration events. There were also fewer major bleeding events in the large-bore mechanical thrombectomy arm, though the trial was not independently powered for that endpoint. Intensive care unit utilization post-procedure was significantly lower in the thrombectomy group. Patients went home faster and spent fewer hours in the intensive care unit.
The intuition makes sense. You are removing the clot mechanically without putting a thrombolytic into a bleeding risk patient. No thrombolytic exposure means less risk of spontaneous bleeding, including intracranial hemorrhage. PEERLESS 2, published in 2024 in the Journal of the Society for Cardiovascular Angiography and Interventions, compared large-bore mechanical thrombectomy to anticoagulation alone and also showed faster right ventricular recovery and shorter intensive care unit stay with thrombectomy.
So we now have two randomized controlled trials showing large-bore mechanical thrombectomy is favorable for intermediate-risk pulmonary embolism, one against catheter-directed thrombolysis and one against anticoagulation alone.
Now, let us be fair about the limitations. KC.
PEERLESS was sponsored by Inari Medical, the manufacturer of the FlowTriever device. Industry sponsorship is a real source of bias even with independent statistical oversight. The trial was open-label because you cannot blind a surgical procedure versus infusion. That means clinicians may have been more vigilant in one arm, which can affect adjudication of soft endpoints like clinical deterioration. The catheter-directed thrombolysis arm had no standardized protocol. Different centers used different catheter systems, different doses, different infusion durations. So the comparator was heterogeneous.
And follow-up was only 30 days. We do not have data on post-pulmonary embolism syndrome, exercise tolerance, or recurrent pulmonary embolism at 6 or 12 months. Large-bore mechanical thrombectomy also requires specialized operators and equipment that are not universally available, particularly in community hospitals.
I think it is worth stepping back and explaining the risk stratification framework in a bit more detail, because it is foundational. How does a hospitalist know when a patient with pulmonary embolism is intermediate high risk and should be considered for intervention?
Great question. Intermediate risk means the patient is hemodynamically stable, systolic blood pressure above 90. Within that group, intermediate high risk means they have evidence of right ventricular strain, either elevated troponin, elevated brain natriuretic peptide, or right ventricular dysfunction on CT or echocardiogram. That combination, hemodynamic stability plus right ventricular strain, is the target population for the PEERLESS trial and for most pulmonary embolism response team activations. Intermediate low risk means stable with no right ventricular strain, and those patients typically do well with anticoagulation alone.
And the pulmonary embolism response team model exists because the decision to pursue intervention is complicated. You need imaging to confirm the right ventricular dysfunction, you need to assess the bleeding risk of the individual patient, and you need someone who can perform the procedure. The pulmonary embolism response team brings all those specialties together in real time, so no one person is making this decision in isolation at 2 a.m.
Well said. As a hospitalist, even if you're not part of the pulmonary embolism response team, you're the first one to recognize that this patient's hemoglobin or right heart strain tells a story that needs escalation. The earlier you escalate, the more time the team has to plan and the better the outcomes. Know your institution's pulmonary embolism response team activation criteria and activation pathway.
Current ACC and AHA and European Society of Cardiology pulmonary embolism guidelines were published before PEERLESS and do not yet fully incorporate these data. Updated guideline versions are expected. For now, the most common practice framework is the pulmonary embolism response team model, where interventional cardiology, pulmonary and critical care, vascular surgery, and hospital medicine collaborate in real time on each intermediate-risk pulmonary embolism case.
As a hospitalist, your job is to know the risk stratification framework, know when to activate your pulmonary embolism response team, and understand what the options are so you can have an informed conversation with the team and with the patient. High risk gets systemic thrombolysis or surgery discussion. Intermediate high risk with right ventricular dysfunction in a patient at your institution with thrombectomy capability. That is now a very strong conversation for large-bore mechanical thrombectomy given PEERLESS data. PEERLESS changes the conversation around intermediate risk pulmonary embolism. Large-bore mechanical thrombectomy is now the leading catheter-based option when technically feasible, with a favorable composite efficacy and safety profile compared to catheter-directed thrombolysis. Know your institution's capabilities and use that pulmonary embolism response team. Thanks, KC. This was a high-yield one for the wards. We'll see everyone in the next episode of AZIN's Journal Club.